And what about cognitive behavioral therapy? Have you all heard of cognitive behavioral therapy? CBT, they call it sometimes. So that's, it's as effective as antidepressant medications in mild to moderate depression. In severe depression, you may want to first treat with medications. Basically, there are no physical side effects. Everyone has automatic thoughts. We all think in stereotypical ways, and sometimes our ways, they're automatic. We don't even realize how we kind of think in certain ways, and sometimes those things can get us into trouble. Someone mentioned earlier about feeling like you're a burden or not a function to your family because you're fatigued, and actually someone might have a thought, I am a burden to my family, and it might get them into trouble where they feel more and more hopeless. And so what cognitive behavioral therapy does in a structured way is to challenge those thoughts in a good therapeutic alliance where you say, well, do you really think you're a burden to your family? How helpful is that to you? Behavioral activation is another part. The behavioral part is getting people to actually exercise and get socially activated, get into pleasant events and things like that. And so what has this kind of therapy, is there any evidence that it actually works? So what about cognitive behavioral therapy for depression in patients with diabetes? So again, Patrick Lustman, who's done a lot of studies, he's at Washington University in St. Louis. He and his colleagues randomized 51 patients with type 2 diabetes to 10 weeks of CBT or a control group. There were no antidepressants, and all patients received diabetes education. So even the control group got some attention. Intervention group had significantly greater remission from depression. Post-treatment, 85% of the treated people, compared to 27%, had a response. And at 6 months, that response continued or persisted. So this is from CBT over only 10 weeks. Intervention group had significantly lower hemoglobin A1Cs. It was about a 1.3% difference. So this was a group with very high hemoglobin A1Cs, and maybe not your typical primary care group. I want to talk here a little bit about, this is kind of based on cognitive behavioral therapy, and I use this all the time. So this is something that I find, it's nice to have little things sometimes that you use all the time. In the clinic where I work, I often get patients sent to me who are eating too much, they're regulating their feelings with food or whatever, and they call it the ABCs, the antecedents, behaviors, and consequences, and I used to have alternative behaviors, and I was giving this talk the other day, and I said, gee, I wish there was a D, and they said, well, why don't you say different? So I added different behaviors, and now I call it and I didn't start the ABC thing, but the ABCD thing. So you've got antecedents, behaviors, consequences, and different behaviors. Now, the reason this is important is, so you have someone that comes to you, and they say, I'm eating chocolate bars at my break, and the doctor says I've got to stop doing that, and I just can't do it. Remember that quote, I know what I'm supposed to do, know what I'm not supposed to do, but I still don't know why I'm doing it. I still do them, and I don't know why. So the person might say, I'm eating chocolate bars at the break, and I'm not checking my glucose because I know it's going to be high. That's usually what they say. And then if we ask them about complications, basically they say, I have feelings of guilt or shame. My blood sugars are usually higher, and I've gained weight. I know I've gained weight ever since I started doing this about 3 weeks ago. I'm tired. I can't get my work done. And that's usually where we kind of go with this. We go, okay, well, gee, that's a real problem. And what this forces us to do is to sit down with a piece of paper, or you can make this on Word with tables, how many columns? 1, 2, 3, 4, 5 columns. And two rows. It's very easy. You just put your little thing in, and you sit down with the patient. You say, okay, listen, now let's talk about what was going on before that. And you also give them one of these to take home with them. And you say, well, what was going on before you started doing it? Before you go down for the chocolate break, what are you thinking? Do you know what's happening out there? Is there something that's triggering this? And often they can bring up a point. So this person, this was an amalgam of some cases that I was doing this with, but the person was saying, feeling left out. I have the wrong job. I feel really resentful towards the other women in my organization because, they're professional and I took time out to raise my kids. I just don't feel good enough. And whenever an issue came up that really exacerbated that or amplified that, she felt bad. And so now she was starting to get an idea of a pattern. And it was no longer just the B's and the C's and a cycle, because remember, the consequence feeds right back into it. Often feeling guilt, shame, and all that makes you feel worse, and you just start getting into a cycle. But now we're looking at what was the antecedent before that. And so then you also want to go over with them, what are alternative behaviors? In the past, when you felt lousy or down in the dumps or whatever, what would you do? Well, I sometimes would discuss problems with my friend or my sister. But then maybe with this thing, I could seek a new job. You know, I was thinking about doing that, but I haven't started it yet. Or, you know, in the past, I've set weight goals with a friend with diabetes. And all of a sudden, you've got sort of the bookends, not just this cycle in the middle, but you've got the antecedents, which is very important. And now you've got alternative behaviors, almost like a menu that they can pick from. And it's incredible how much this breaks the cycle. Does that make sense? And it's very simple. It's something you can do right there with them and send them out. A few weeks ago, a librarian came back after 2 months, so I gave her a stack of these. And she filled out tons of them. And she said, I've stopped, you know, doing this. I'm crocheting now. I'm not eating anymore. And very happy. It really works. So that's not necessarily treatment for depression, but something that comes with depression. And of course, it's based on cognitive behavioral therapy, looking at patterns, looking at things, and changing those patterns. What about the evolution of antidepressants? So we've talked about therapy. What about antidepressants? So I think people usually like if I can kind of quickly go over these. And I didn't put in the trade names of all these. These are all the tricyclics here. Okay, in the 1960s, well, there's imipramine and all these tricyclics. Then there were the MAOI inhibitors here. We don't really use many of these. Sometimes the tricyclics, like amitriptyline, you'll see someone still on amitriptyline or Elavil for neuropathy pain, 25 to 50 milligrams. It's a very dirty drug. Maybe at smaller doses it's okay, but it has a lot of side effects, including cardiovascular side effects. So you have to be very careful with it. It can cause orthostatic hypotension, which means when you stand up quickly, you can get dizzy. It can cause weight gain and so on. Nortriptyline or Pamelor. But we really don't use these very much. Perhaps, like I said, maybe in depression, we use it for the neuropathy pain, but sometimes we use it as an add-on to help with sleep because these are usually sedating medications. And then in the 70s, there are two drugs that we don't really use anymore. This is just here for completeness sake. And then in the 80s, there are a number of drugs here, so I'll go over these. Bupropion, which is Wellbutrin, and trazodone is Deseril. Fluoxetine, sertraline. So fluoxetine is Prozac, sertraline is Zoloft, paroxetine is Paxil, fluoxamine is Luvox, citalopram is Celexa. You've got nifazodone, mirtazapine, and venlafaxine. Nifazodone is Cerazone, and that medication is actually off the market in some countries because of fulminant liver failure. 1 in 250,000 patient year risk. Minuscule risk, but it's fulminant liver failure, and it went off the market, and here in this country, it's also being kind of phased out. So that's nifazodone, but again, here for completeness sake. Mirtazapine is Remeron, venlafaxine is Effexor, and then duloxetine is the newest drug on the block, and that's called Cymbalta. So I already talked about tricyclics. They have what's called anticholinergic effects. They can cause blurred vision. They can cause urinary retention, constipation at higher doses. Antihistaminic, meaning they can cause sedation and weight gain. Orthostatic hypotension, meaning they can cause dizziness when you stand up quickly because they basically expand your vessels. And then cardiovascular side effects. They can even cause what's called proarrhythmias, and at higher doses they can cause arrhythmias. But they used to be used all the time until the mid-80s, and they're very effective, and we still use them. Clomipramine, one of those, has very high serotonin levels, and so we still use that one a lot in OCD, where you need very something that really affects serotonergic transmission, or where it suppresses reuptake of serotonin. So then you can have increased carbohydrate craving. It causes weight gain. It can cause fasting blood sugars to go up, and so on. And the mechanism may include suppression of insulin secretion. Now, what about antidepressants? What kinds of studies? So if we look at the newer medications, are there any studies of just the antidepressants in patients with diabetes? Again, Patrick Lussman and his group, they've done so many great studies. Another randomized control trial, only 60 people, but still, they had both type 1 and type 2 patients with major depressive disorder, and they received up to 40 milligrams a day of fluoxetine over 8 weeks. they had a reduction in depression symptoms, and it was significantly greater in patients receiving fluoxetine compared with placebo. There was a greater reduction in hemoglobin A1C, but it didn't reach statistical significance, and that was observed in the treatment group, the fluoxetine group. So the reduction wasn't significantly greater, but there was definitely a reduction. When you pick an antidepressant, you want to think about the sedation profile. I just did a meta-analysis for one of our up-to-date chapters, and actually there was a recent meta-analysis actually in Annals of Internal Medicine, I believe, and it showed that one of these drugs, this one here, interestingly, has a faster onset. We usually talk about how none of them really is any faster than any of the others, but actually this one large meta-analysis showed that mirtazapine actually has a faster onset, that's Remeron, but at 4 weeks there was no difference in terms of rapidity at which people got less depressed. So I think that's just kind of an interesting finding. I'm not sure we should all flock to get people on mirtazapine, and anyway, mirtazapine is associated with weight gain. So you have to be very careful. It has antihistaminic effects, which means that people get sedated with it. It's a drug that you give at night, but it can also cause weight gain. On the other hand, for patients with type 1 diabetes, where they're not as concerned as with weight, I use it a lot. It's a great antidepressant and anti-anxiety agent. So again, going back to this slide here, you've got sedation on the left side, activation on the right side. And again, this is rule of thumb. This isn't, I kind of looked at some charts, and this is my clinical experience and so on. And you're going to see patients where they're completely on the other end, anomalies. Some people I know get sedated. I just had a patient recently that got sedated on fluoxetine. I hardly ever hear that. That's Prozac. Or citalopram, they take it at night because it's sedating. But most of the time, this is pretty accurate here. So mirtazapine or Remeron and trazodone are quite sedating. So if someone is very agitated and they're not sleeping, that might be a good medication to choose, like the mirtazapine, for example, if they don't have a weight problem. On the other hand, if someone is psychomotor retarded or even sloth-like, then maybe we want to choose a medication, fluoxetine, which is Prozac, or Wellbutrin, which is bupropion. Now, interestingly, bupropion actually, I have so many patients when I start them on it, they start to feel better within a week or two. And it's like the side effect of the bupropion, and it starts to make them feel a little more activated. It's interesting. I know that it isn't a depression treatment. And a lot of people just say, gee, I feel just great after 1 or 2 or 3 weeks. But I don't think that's the antidepressant effect yet. And then you've got all these antidepressants in the middle here. So that's one of the criteria that you choose an antidepressant for someone is, are they either really agitated and they can't sleep, or are they on the other end of the spectrum where they're sleeping all the time and they have such low energy? So that's often one criterion. Other criteria are considering weight gain, which we already talked about. So you wouldn't pick a tricyclic, you wouldn't pick mirtazapine if someone had a problem with weight gain. Autonomic neuropathy, that's a kind of neuropathy in your central part of your body, not in your feet, where it affects your vessels. And so what happens is, again, you get that thing called orthostatic hypotension. Hypotension means low blood pressure, so when you stand up quickly, and so people with with autonomic neuropathy can get dizzy and faint and so on. So you have to be careful that you're not giving a drug like trazodone, for example, that has what's called an alpha block effect, alpha blockade, that expands vessels and can exacerbate that in people with autonomic neuropathy. The other thing is the direct effects of the antidepressant on glucose. We saw that with imipramine, for example. Comorbid anxiety versus glucose dyscontrol. And a lot of people have, anxiety. I've had patients that, they check their blood glucoses when they're having a lot of depression and anxiety. I had one patient that checked her blood glucoses 11 times in an hour. She was sure she was having hypoglycemia, and it was really the anxiety she was having. She was close to having panic attacks and so on. And so that's very common. So you want to consider, if you put them on something that's very activating, yes, in the long term it might help their anxiety, but it might just make things even worse in the short term. Patient adherence, if you can get someone on a medication once a day instead of twice a day, that's important. So even with bupropion, Wellbutrin, there's now, the original form was given 2 or 3 times a day. Then there's SR version, sustained release, which is also generic, which is twice a day. And now there's an XL version, which is not generic, and that's once a day. With venlafaxine or Effexor, there's also an XR version, which means extended release. The regular form of it can cause a lot of GI symptoms. And then there's also sexual dysfunction. You know, up to a third of patients taking SSRIs might have sexual dysfunction, lack of libido, inability to get an erection, inability to ejaculate. And it may result from depression or diabetes, and there may be antecedent depression, it may antecede depression, or it may be related to the antidepressant, or all of the above. So I never make any promises, but often people will come to me and say, look, I just don't want to be on this medication anymore. So you have to have strategies. So sometimes, if it's appropriate, decreasing the dosage or watching for habituation. This one I really wouldn't recommend, but if someone's been on antidepressants for 10 years and they're completely stable, and they said, it's doing me a world of good, but I just don't want, and I don't want to start anything else. You could try this one day, kind of like, you stop the medication for one day, there's a one-day washout, and it actually reverses the sexual side effects for like half a day. It really does work. But I wouldn't do this with anyone that you're treating where there's any risk of them relapsing. It's hard enough to have people take their medications. Sometimes adding Buspar, especially if they have anxiety, but there's been some anecdotal evidence of buspirone, which is used for anxiety, that it can reverse side effects. And then sometimes adding bupropion, which is the Wellbutrin, adding a little bit, which we often do as an augmentation strategy, or switching them to Wellbutrin or to mirtazapine. Those two medications, bupropion, Wellbutrin, which is known as Wellbutrin, and mirtazapine or Remeron, doesn't cause as much sexual dysfunction. So, venlafaxine. So I just want to finish up here with three or four slides. The venlafaxine is used. There are 3 randomized control trials that I want you to know about. So venlafaxine or Effexor has been shown in randomized control trials. This is, I think, shows 2 different studies that it has in non-depressed patients. Compared to placebo, it lowers neuropathy pain related to neuropathy. So if you have someone with neuropathy pain, it's something to consider as a selection criterion for what antidepressants you might choose. And then they don't have to be on other anti-pain things like or even gabapentin or maybe Elavil or whatever. So there's parsimony in that and just choosing one medication. Bupropion in neuropathy, another randomized controlled trial, again in non-depressed patients, and again it showed that there was a decrease in pain compared to placebo. And then finally duloxetine, which is Cymbalta and neuropathy pain, and again another RCT, or randomized controlled trial, that again showed in non-depressed patients, and I think, and Lilly has an FDA approval just for neuropathy with Cymbalta. So when should I refer? If you have concerns about suicide, so that would be, again, an issue where you'd want to refer maybe to a psychiatrist or a mental health professional in your clinic. You're just, you've asked the question and they said, yeah, they have thoughts of wanting to hurt themselves. And of course, there's a whole spectrum of what they might actually do. But if you don't feel comfortable with it, make sure you have someone to refer to. What about if you're getting a sense that there's psychosis, or you've asked those questions about bipolar illness? And again, if you don't remember them, you can just go to the web and find out what the criteria are, or look in a book, and just try to memorize most of those criteria, or just have a piece of paper. So whenever you're talking about depression, you can quickly ask those questions. And if you suspect it, you can refer on. Pregnancy, we always get asked to see people and decide whether they should be on an antidepressant or not, and which one to choose if they're pregnant. Severe medical illness, personalities, or a colleague of mine has this thing called the lunch question as a probe. He asks himself, to see if they have a personality, or he's asked himself, would I go for lunch with this person? I call this diabetes-focused depression care. I kind of distilled all this down, and I've been using it for years. And then my colleague Wayne Caton and I just contributed to Kaplan and Saddock's. It's a psychiatry textbook. So I decided to throw this in. So there's going to be a version of this in there. But I think this is just from my experience, one way to approach people is like, well, assume that depressed patient is experiencing a loss of control. They're not coming with depression stamped on their head. They're just confused. They're having all kinds of symptoms. They're confused about their experience, about their symptoms, about all kinds of stuff. And the sooner you can say, gee, you know, this must really feel confusing to you. You've lost control of your symptoms, your glucoses are out of control, all kinds of things might be out of control. Assess for an understanding of their link between stress and suboptimal self-care. And then you can move to talking about, you know, distress, stress, depression, anxiety, and kind of just teach them a little bit. Again, these are such important things. If you can do it in that first appointment, we call it psychoeducation, just educating them a little bit about the psychological aspects or behavioral aspects of what's going on for them. It can make a world of difference. And their self-blame goes down, and they start to understand, they feel less hopeless about it. Define depression and how it overlaps and is distinct from distress. You might want to do the PHQ-9 and go over the symptoms with them. Review the symptoms of depression and how they overlap. Those middle symptoms, remember fatigue, sleeping too much, things like that. Go over those things and say, gee, you know, this may not just be your diabetes, this might also be the depression that's going on. Discuss depression-related symptom amplification. It's so helpful for patients to hear about that. Consider biological sequelae or consequences resulting from comorbid depression. So when we think about why things go wrong, I have patients that say, you know, I've started using more and more insulin and I just can't keep up with it. And I just don't know why. I'm trying my very best. And often in that case, you just know there's something biological going on. There's something we call the HPA axis, the hypothalamic pituitary adrenal axis. You know, that whole thing with sympathetic outflow, that, you know, fight or flight hormones. And they just can't keep up with it. And their blood sugars are getting out of control. They have anxiety and depression. They're doing their best. And there's just something that they need to hear is like, you know, no matter what you do right now, until we treat your depression, it may not get better. And that's what Earl Hirsch says to me and says to patients, until you get this depression treated, you know, I may not be able to do anything for you. That's the mantra. And I think that's really something to keep in mind here. And then, of course, there are behavioral sequelae. We already talked about those. You know, lack of motivation, poor concentration, you know, confusion, disorganization, and so on. Then you want to screen for comorbid anxiety and panic attacks. Very important, because that's so common, comorbid anxiety is with this. Screen for associated eating concerns. Talk about night eating, grazing, you know, eating too much. Do you ever regulate? I see this so often. How do you cope with this? Or do you have a loss of appetite? Yes, I do, but I'm eating the wrong foods. They're not hungry, but they're still eating, and they're eating all the wrong things, and they're saying, I'm just trying to feel better. And they're acknowledging it. And again, it's worth acknowledging that, and that's really hard. And that part of this is regulating. It's a universal phenomenon. We all can regulate our feelings with eating. And again, it makes them feel better to know that other people do it too. Almost everybody can do that. Assess psychosocial stages of diabetes, like I showed you in that chapter, you know, or you're thinking of it at least. Is there something, is this new onset? Have they developed a recent complication? Are they just getting burned out with this idea that they have to do this for 20 years and they're so overwhelmed? Or, you know, those kinds of things. Break down the tasks and help patients prioritize. That's so helpful. They've got a cloud. One of the things that we've done, I'm doing a randomized control trial right now with patients with epilepsy. And I've done it before with frail elder. We do something called problem-solving therapy. Simple thing. We can all use, you know, those skills of problem-solving, but we've used that clinically. And with frail elderly, we had, you know, three times as many people that got problem-solving as people that had remission from their depression. People are often just overwhelmed with things. They can't work their way out of all the problems they have. So if you can help them prioritize, it's just a simple thing sometimes. They feel so overwhelmed, it's like a black cloud. And if you can help them take one goal at a time, and that's the problem solving. And for patients with comorbid anxiety, consider using an SSRI, a serotonin-specific reuptake inhibitor, or serotonin selective reuptake inhibitor. And basically what that is helping, picking a medication like the fluoxetine, sertraline, you know, citalopram, fluvoxamine, or the paroxetine. Those are the SSRIs, or the SNRIs. N stands for noradrenergic, so serotonergic and noradrenergic. And those are the two medications, venlafaxine and duloxetine. Those can also be very effective with anxiety. And then consider, going all the way up here, number 12, for patients with sexual dysfunction, consider bupropion, which is Wellbutrin, or mirtazapine, which is Remeron. For patients with neuropathy pain, consider the 3 that I've talked about that have all been shown in randomized controlled studies to have significant effects on pain in non-depressed patients. And those are bupropion, which is Wellbutrin, venlafaxine, which is Effexor, duloxetine, which is Cymbalta. And then consider adjunctive brief psychotherapy, or without using medications, that's the main treatment. But CBT is one, and also for emotional eating, or just CBT, cognitive behavioral therapy for the depression. I already talked about problem-solving therapy, motivational interviewing to help with enhancing their motivation at a time when they're so depressed. That can sometimes be helpful. And improving effective patient-provider interactions. Sometimes that's kind of falling apart. And is there a way that we can do something to help with that? Maybe as a team, maybe someone can spend a little more time just to work out how to work more collaboratively when they're feeling so isolative, perhaps. And there's some useful websites. And I'm going to stop there for questions. So thank you very much.